Good evening, everyone. How are you all? Welcome to First Aid AMC Clinical Free 2-week session again. So, as you know that I'm Dr. Arshan and we have been conducting this free 2-week session for the new clinical course that's just started from 7th of January, right? So, we had few sessions already. So, first session as part of a trial class that you guys had with us, that was on 7th of December. And we did the intro of AMC clinical exam. And then on 7th January, we did a psychiatric class where we mainly focused on psychiatric basics. And you also got to understand how to take a history and how to present mental status examination findings to the examiner. So that was the focus of our last few sessions. Tonight's session, you will learn about how we conduct our role play classes. Our course is designed in this way. It's not only just showing you what to read and just be done with it. We also make sure that you get to do a lot of role play with us during the course. And there is not a huge amount of students that we allow enrollment. There is a set amount of doctors who will be enrolled. And ideally, we make sure each and every one of you can do the like unlimited amount of role plays as much as you want. So if you are joining our live sessions and if you are willing to do role play, there will be a there will be a tremendous amount of role plays that you can do because there are lots of role play sessions that we conduct during this 5 months course. So tonight's session is not about any theory discussion. It's about doing some cases, which is very important for exam. And we will be focusing on mainly the psychiatry mental status examinations that we have done in our last session. Okay. So do you guys have any questions from our last class? No? Okay. I hope you guys did some role play with your study partners. I hope you did few study about those cages and about the MSc history taking so that you can do some role play with us today. So who is willing to do the first role play? So remember, every one of you are beginners and you will do a lot of mistakes. And that's all about the course is. We want to make sure that you do mistakes so that we can give feedback to you so that we can make sure that you understand how to do the history, how to come to a proper diagnosis and get passed in the exam. Dr. Sanim, are you a MCQ student? This is not a MCQ class. This is a clinical course class. So if you are a MCQ student, please do not join this class and you wait for our MCQ class that's going to happen in few days again. Okay. All right. So who is willing to do role play? Come and do some role play. Otherwise, there is no meaning of doing this class.
So I'm happy to go first.
Brilliant. Who is it, Dr. Tharindo?
Yes.
Good. Very good. All right, let me give you a case. I'm just going to stop sharing this screen and just in a few minutes we will start. Just give me a moment. All right, let's do this case. All right, so Dr. Tharinder,
Yes, sir.
the case that we are going to do is this one. So just 1 second. Now, the case, because in here, you'll not be able to comment on the appearance and behavior of the patient. So for today's sessions, keep all the appearance as well groomed, and behavior, just say that, just do all the negative behavior, like patient is patient is not having any stoop posture, not restless, not fidgety. So give some negative findings, and
Mhm.
that should be how we're going to do it tonight. Okay, so appearance will be well groomed, and in case of behavior, you can just say that patient was cooperative, patient was not having any restlessness, fidgety, not responding to any unsafe stimuli. So just give some of those information that we are looking for in the behavior. And in exam, if you get any of them, just say, yes, this patient had this kind of behavioral things in there. Okay.
Yeah.
All right, brilliant. So this is your case. As part of any case, you'll get in the exam, you get 2 minutes to read a case and prepare in your head, and you get 8 minutes to do the case. But because you lose some time when you go into the room and examiner talks to you, examiner then introduce yourself to the patient. So you lose about 30 seconds during this time. So we always do role play. The case will be 7 minute 30 second instead of 8 minute when you practice. Okay,
Yeah.
so you will get 2 minutes to think, but we will give you 7 minute 30 second to do this case. All right, so your time of 2 minutes just started.
So are you going to tell me when the time is up, or?
Yes, I'm going to tell you when the time is up. Now remember, you can't write anything on your paper at this time. If you need to write anything, you can only write it when the time starts. Okay.
Yep.
All right, Dr. Tharindo, this is your patient. Your patient name is Sam. You can start.
Hi, Sam. My name is Dr. Thaindu. I'm one of the doctors at this clinic. I'm here to help you today. Just before we start our consultation, I just want to show you that whatever we talk today will be between us, and unless it is harmful to you or others, this
Okay.
information will be confidential. Sam, I heard you were feeling anxious. Can you please tell me more about how you are feeling today and what brought you into this clinic?
I just feel like it's bothering my head for the last 6 months. I just can't shake that thought, and it's very embarrassing for me to tell to you. So I just don't know how to start. It's just so annoying. I can't stop thinking about this annoying thought, which just keeps my whole 24 hours. I just keep on thinking about this. So and I'm just very tired about it. So I'm just thinking like if you can help me to get rid of this thought.
Sure, Sam. Thank you for sharing that with me. I'm just going to run you through some questions. Let's just start with your mood. Can you please tell me how your mood is like today?
I feel like I'm a bit worried feel anxious most of the time.
Okay, how about your sleep and appetite? Are you sleeping well, or and also are you having your meals?
Yeah, it's okay.
Do you have any thoughts of wanting to harm yourself or
No,
anyone else?
no, I don't.
All right. I'm just gonna ask you some screening questions. They may seem a bit strange to you. Is that all right with you?
Yeah, sure.
All right, Sam. Do you see, feel, or hear things that others don't?
No, I'm not.
Okay. Do you think someone is spying on you or trying to harm you?
No.
Do you think you need some medical help?
Yes, I do.
All right. Thank you. Just give me a second. For example, let's say that there's a fire in this room. What would you do in such a scenario?
I'll just run.
Okay. Where are you? Where do you think you are now? Do you know what date it is today as well?
Yes, I'm in the clinic and it's Sunday, 11th January.
Okay. Do you smoke or drink alcohol?
No,
Do you have any past medical histories of mental health illnesses?
no,
Okay. Any change in weather preference for you?
no,
Any head injuries?
no,
Do you have any flu-like symptoms?
no,
Do you have any family members suffering any mental health illnesses?
no.
All right. Um, okay. All right, Sam, thank you for
I
that.
just can't shake that thought, doc. I just feel like it's just keeping my head is gonna burst. I just don't know what to do about this thought.
And is there a time that you feel like this, or is it you feel like this all the time?
It's constant.
It's constant. Do you feel like this when you're around a lot of people or when you're by yourself?
It's
Within
like it can
a
happen
year?
anytime. It can be anytime.
Anytime. Okay. All right. Um, yep. Thanks for that information, Sam. I'm just going to present this case to my supervisor now, if that's all right with you.
Sure.
Okay. Um, Dear examiner, I'd like to present this case, this mental health examination of my patient Sam. Um, um, his appearance is he's well groomed. He's cooperative. He's maintaining eye contact. His speech is normal in rate, volume, and tone. It is and he did say that he's feeling tired constantly and annoyed, and he's feeling anxious most of the time with a headache that is constant. He did report that it does not happen in around crowded people, but it's pretty much a constant time. His emotion, his mood and affect, according to the patient, his mood is quite low, and the effect I observe is conjoined with his mood. He does not report any hallucinations. His thought form is linear, and he doesn't have any flight of ideas. Not the thought content is not. He's not delusional. Not having any overvalued ideas. Um, with cognition, he's orientated to place and time. Um, there is no risk to the patient of suicide or any other harmfulness to anyone else. Uh, Patient somehow maintained a good rapport with me. Um, Reliability wise, the history I believe given was reliable, and but just to be sure, I may request for a collateral history from a family member just to be sure. Thank you.
Thank you, Dr. Tharinder. Very good. I'm very happy how like how you did the case, but not happy about few important things that you missed. But again, as a beginner, Dr. Tharindo, how fluently you're talking, how you're asking questions, really happy with that. So now, before I go into a discussion about this case, I want to just ask one more candidate to ask few more questions to me, what Tharindo might have missed. Anyone who wants to just,
Hi, Doc. I can do that.
yes, who is that?
Is
Dr.
Dr.
Sajan?
Saj? Yes.
Good. Okay, so let's try, just ask the things that he has missed.
Okay. I think I should start with the beginning. Is okay?
Yeah, go for it.
Hi, Sam. This is Dr. Sajan, one of the GP in this clinic. Very nice to meet you.
Nice to
Um,
meet you, doctor.
okay. Thank you so much. Hi, Sam. How you are here today? Let me tell you the one thing that I feel that you are anxious, and this is a very safe place. And let me reassure you that what we'll talk, it will be in between you and me, unless you are at a risk or others are at risk. So please open up me. What can I do for you today?
I just feel very anxious all the time, doc, and these thoughts are coming into my mind. I just can't shake this anymore, so I just need some help.
I'm sorry to hear about that. Can you tell me more about your thoughts, Sam?
Yes, so it's very embarrassing for me to say, but I'm just going to say it. So I think that my mom is having sex with my uncle. And I know it is not possible because they don't even live together, they don't even see each other. But I just I can't stop thinking about it. It just happening every day, every hour, and it's just too much for me to handle now.
Oh, I'm sorry to hear that. Okay, how long this has been going on?
Just last 6 months.
Oh, I'm sorry. When the thoughts come to you, what will you do?
I just have to stand up and move around the room a few times.
Okay, and then why do you do that?
I just can't stop thinking about it unless I do it. I have to do it, otherwise the thought becomes more and more intense.
Okay, yeah, I'm very sorry to hear that. I'm coming to you that. Can I ask you a few more questions about that?
Definitely.
Okay, can you tell me about your mood? How this mood has been with you?
Um, I'm just feeling very worried and anxious these days.
How about your sleep and appetite?
It's okay.
Okay, that's good. Do you have any, when the thoughts come to you, do you think you want to harm yourself or harm anyone?
No,
Oh, that's good. That's great. Okay, tell me about that. Do you hear any voices or any feel anything on your body or see any person the others don't?
no,
Okay, that's good. What about do you think that someone is spying you?
no,
Okay, do you think that someone is inserting these thoughts in your mind?
no,
And do you think someone is broadcasting your thoughts?
no,
Oh, that's good. And do you think that someone is looking on you?
no.
Okay. Hi, yes, Sam. Okay, that's fine. I might ask you the few things that's like look you to odd to you, but it's just a routine. Don't be embarrassed. Okay. If there's a fire in this room, what will you do?
I'll run.
Okay, that's good. And do you know where we are?
Yeah, we're in the in the clinic.
Who am I?
You're the doctor.
And what day is today?
Sunday.
Okay, that's good. Okay, yes, Sam. That's good. What about tell me more about do you drink, smoke, do you smoke cigarettes?
No,
Do you drink alcohol?
no,
How about any drugs?
no,
Okay. And do you take any medication or you do anything for these feeling, all these thoughts of anxiety?
not really.
Do you drink a lot of coffee or anything?
No.
Okay, that's good. Yes, Sam, I can understand you that. And let me give you a minute. I'm going to present this your presentation to my examiner.
Sure.
Dear examiner, I'm going to present the mental state examination of the Sam. Um, who has presented with an anxiety symptom of the thoughts that's bothering him. His appearance is well groomed and looks appropriately kempt. His speech is little low and little monotonous, but he don't have any other abnormalities of the speech, no other things. His emotion, his mood looks little anxious, but and the emotion is congruent. And what about he denied any auditory hallucination, and he denied the thought form is a linear, and the thought content he denies any delusion, any kind of a delusion, no paranoid delusion, no thought insertion, and no any thought broadcasting. Sam, I forgot to ask the inside. I believe that he's come here to get the medication, so I forgot to ask inside. And his cognition is good, and his judgment is normal, and I maintain the rapport, though he looks very fidgety and anxious, but still I was able to maintain the rapport, and he don't have any risk, but is a possibly there's a moderate risk because of the ongoing thoughts, and he runs when he gets the thoughts, and his history looks reliable, and I will believe to get some more history from the other relatives or things. Thank you, Alexander.
Thank you. Very good, Dr. Sarjan. Very happy with how you asked the history. I'm really happy how you started asking about those thought questions, which is really important. Um, because the thing is that we do the format, the format is always there, but you can't just don't ask the main complaint. Always make sure that you guys ask the main complaint in detail. If the role player gives the history that yes, I've been having some thoughts, you have to explore those thoughts because the essence of the case is actually in that area. And if you don't ask more about it, you will not get any positive findings, which Dr. Tharendra could not find out initially because of that. But he also did take a good history. And Sarjan also did take a very good history, but the difference between these two is Sarjan explored the thought questions and he got a lot of findings. But unfortunately, he did not add that in the MSc finding. Now, I want one more candidate just to tell me, we're not going to do the full case anymore, just to tell me what else we could ask in this case. What's missing still now?
Can I tell?
Yes,
No. So in
Sanjay?
this, I think, thank you so much. In this week, I think we need to ask about any recent head injuries, any infections, and so many um, head injuries, infections, and so
No,
many
not very important, Sanjay.
substance use.
Not very important because it's not under the MSc. So something that is very important to present in the MSc.
Okay.
So can I tell, like we can ask for stressors at home or at work, and we didn't ask that. Do you have any support, and are you taking any drugs or any medications?
Yes,
We
so
can
heads,
ask
we can
that.
ask heads and SADMA. Again, it's important. If we have time, we can definitely ask them. But again, it's not the most important for MSc. What else? Can we ask anything else to explore the thought a bit more?
So I need just to please to tell. So we need to ask him why you think like that. What makes you think that there is like a sexual relationship between your mom and uncle? What makes you think? Do you feel or do you see there is some attraction, some some action from your uncle towards mom? How is the relation of your uncle to your mom like that?
Okay.
Okay,
All right.
I can add on. I think I forgot, we should ask them, do you think your thoughts are real, or you just to make sure that is a delusion or just a.
Yeah, the thing is that I already said that I think it is not possible, right? When I think I told it to the first Dr. Tharindo, like not Dr. Tharindo, Dr. Sarjan, because you were asking about it maybe. But I mentioned that it is not possible. So that makes sure that I know that it is not possible, but still I'm thinking about it. What I'm trying to find out from you guys is that any patient who has obsessive compulsive disorder. This is a OCD patient. You guys got that, right?
Yes.
We need to find out what else. Multiple thoughts can be there in this patient, and that's a positive finding. So if you guys ask me that apart from these thoughts, do you get any other thoughts?
Oh, I see.
Then I would say that I also need to keep washing my hands. And if you ask me that why do you do that, then I would answer that if I so that was the finding that actually came in exam, which was very important finding. So if I say in here, so the finding that was important is definitely he has overvalued ideas because he thinks his mom is having sex with his uncle, but again, he thinks it is not the case. So we already, like, if I don't mention it, that I know it's impossible, then you have to clarify it with the patient that I understand this must be very distressful for you. So when a person say that I'm feeling very anxious, very worried because I keep on thinking mom is having sex with uncle. What is the next thing you should say? You say that I'm so sorry that you are feeling this way. It must be very distressful for you. But Sam, is there any reason why you're feeling this? Have you seen anything? So you have to then ask because we need to know that is this is a delusion, or is this is a hallucination, is this is a overvalued ideas? Overvalued ideas means that he thinks that is happening, but again he says that no, I know that it is not possible. That is the time it becomes a overvalued ideas. Because if it was delusion, then he would strongly believe that his mom is having sex. So we need to make sure that either it is a overvalued ideas or is it delusion. So that's why we need to ask at that time. But if I have already said that, we don't need to ask it anymore. The other thing is if if you ask me that why do you need to wash your hands multiple times? My answer would be that I believe if I don't wash my hands, aliens will come to the world. So that is a thing that sometimes OCD patients will have. This is called magical thinking. So magical thinking is a symptom or some findings that we get in OCD patient where they have this magical thought that alien will come to the world. So something which is not possible. Okay, so some kind of magical thoughts will be there. So this is not delusion. This is if it is an OCD patient and they have this kind of like unusual thoughts, like magical thoughts, something related to alien, future, something like that, then it's not a delusion anymore. It becomes magical thinking. So how do we know that is it a magical thinking or is it delusion? So magical thinking is belief that one's thought or action can influence the events. Now, that is very important. In OCD patient, this patient will say, if I don't wash my hand, so believe that one's thought or action, aliens will come to the world, can influence the event. So that is how we know. Whereas delusion is a fixed false belief, doesn't have any particular reason, doesn't have any evidence, nothing. It's just a false belief. It's not related to actions that you may or may not need to do. Okay, so that's the main thing. So if patients say, if I don't do this, something will happen. That becomes magical thinking. And if I just believe, no, I believe strongly someday alien will come to the world, that becomes a delusion. Okay. So example of magical thinking is believing that wearing a lucky shirt will lead to success. It's like superstitious, you can say. Thinking that if you don't wish someone well, something bad will happen to them, or engaging in rituals to ward off bad luck. So that means you need to do something to avoid something. Okay? And overvalued ideas are findings that we get in obsessive compulsive disorder patient. And overvalued ideas means that what you are seeing in OCD patient, these are persistent, unreasonable belief. Often sometimes individual know that this is not possible. Individual has insight, but still they can't shake off the thought. So those are abnormal thought, But most of the patients know that these are unreasonable, these are not practical, but they can't stop it. So the main two finding most of you missed in this case, that was the overvalued ideas, and you also did not mention about the magical thinking part because you missed it. If you would ask it, then you would find it. So in this particular case, the history was really good, like how Sajan has done the history, really good. He just forgot to ask, is there any other thoughts that you are having? OCD particularly has some specific questions. When we will discuss the OCD case, there is a different OCD case. You will know the criteria of questions that we need to ask for a OCD patient. But most important question is, what's your thought? How long this is happening? And we need to find out, does this thought preoccupy you fully? Okay, what do you need to do to stop this thinking? What happens if you do not do these rituals? Like if you don't move around the room, what will happen? Patient will say, if I don't move around, my thoughts will become more intense. I will become more anxious. So those are the main things in the history you need to find out. So that's basically the OCD questions. And apart from that, other questions, you just follow the format as Dr. Sargent, Dr. Tharindu has done. That's all that we really need to. In the MSc presentation, I would present this one as, so you will start with, dear examiner, I would like to present the mental status examination of my patient Sam, who came to me with feeling anxious. His appearance was well groomed. He was maintaining eye contact. He was cooperative throughout the session. And as part of his behavior, he was not restless, fidgety. He was not responding to any unseen stimuli. His speech was normal in tone, volume, and rate. There was no pressured speech or disorganized speech. Emotion, he mentioned that he feels anxious and worried. So this is important, that whatever patient says to you about the mood, you have to say that. You can't say patient's emotion was low, because I did not say that. I said I feel anxious or worried. That is the patient's emotion. And the affect that I observed is congruent to the mood. Okay? There was no perceptual disturbance. Thought form was linear. In terms of thought content, he has overvalued ideas, because he keeps on thinking that his mom having sex with his uncle, and he knows that it is not possible. On the top of that, he also have magical thinking, because he believes if he doesn't wash his hand repeatedly, aliens will come into this world. But there was no thought broadcasting or insertion. There was no other delusion of reference, persecution, control, or grandiosity. His insight, cognition, and judgment was normal. He is low to moderate risk. I was able to maintain a good rapport with my patient, and the history seems to be reliable, but still I would like to take a collateral history from his friends or family members. Okay, so that should be the MSc presentation in this patient. Clear, everyone?
Yes, sir. Thank you.
Thank you.
Yeah, thank you.
Thank you. Okay.
Dr. Shan, I have a question.
Yes, Dr. Rida?
How do we differentiate if the OCD patient is having overvalued idea or is it a magical thinking?
Good question. So overvalued ideas and magical thinking always needs to have that, like some kind of belief which is a bit atypical, like superstitious kind of belief. Could be like the term is magical because it's not realistic. Like the one, if I don't wash my hand, aliens will come. If I don't wear that blue shirt, I will not get good mark in the exam. Okay, so those kind of superstitious thought, magical thought, whereas overvalued ideas, those are not magical thinking. Overvalued ideas are some kind of a strong belief where, like the obsessive compulsive thoughts the patient has. So let's say about in obsessive compulsive behavior, patient has that thought that if I don't, like, I keep on thinking that my mom is having sex with my uncle. That's the thought, which I know it is wrong, but I still can't shake it. So that's the idea. And why we call it overvalued? Because we have to do something to get rid of that ideas. And what we need to do, that's the compulsion. The compulsion is I have to move around the room. In the same way, overvalued ideas we see in eating disorder patients, where they think that they are very overweight. They have this distorted thinking about their body image and shape. So, in response to that, what they do is they start doing heavy exercise, they start self starvation, they start vomiting. So, that's the overvalued ideas. Then they think that they are having something abnormal in them and they start doing more things which is overvalued. Same way in BDD, which is the body dysmorphic disorder, someone thinks that their nose is ugly. And because their nose is ugly, that's why everything is wrong in their life. So when overvalued ideas is that they have this thought, abnormal thought in them, and they think that everything is related to that thought, or they start doing some ritualistic behavior to stop that thought. Okay, so to be a magical thinking, it has to be something magical, something which is close to a delusion, but it's not delusion. Does it make sense?
Thank you so much.
Thank you.
Hello, sir.
Yeah.
What about insight? Is in the OCD patient inside is like positive or there is no problem with the inside?
Insight will be intact, because when patients say, I know it is not possible, and if you ask the question, do you need any medical help? Patient will say yes. So that means patient's insight is intact. And OCD patients intact is always going to be intact in this group of patient, because that's one of the main difference between a OCD patient and a schizophrenia patient. Okay?
Thank you.
Thank you.
Quick question, Doc. So it means we have to mention the both things, magical thoughts and overvalue ideas, particularly in this case, right?
If you find those findings, it's not always you will get it, but if you
Mm.
get these two findings, then yes, both overvalued ideas and magical thinking, both will come into the thought content.
Yeah, because in this patient, he said that aliens will come and will destroy
Yeah.
the world. So that's the magical, right?
Yeah.
And overvalued idea is that his mom is doing the sex with the uncle, right?
Yes, that's right.
Okay, thank you.
Thank you. All right, let's move on to the next case. Who wants to do the next role play?
Hello.
Yes?
So it's again MSc, sir?
Yes. Today everything
Yes,
is MSA.
okay, sir, I will try.
All right, give me 1 minute. I'll give you the case. All right. This is the case, Dr. Riaja.
Yes, sir.
And after 2 minutes, we'll start the case. And if you want to start before that, just let me know.
Okay, sir, I'm ready.
All right. Just 1 second. All right, Dr. Riaja, this is your patient, John. You can start.
Hi, Sam. I am
Yes,
Dr.
Mr.
Riazat.
President. Yes, I know I have to come now right now. Yes, sorry, doctor. I just have a very urgent call from Mr. President. So yes, yes, I know the world is at stake. I know. I'm just like I just got stuck in here with the doctor's room. I just don't know what's happening. I know
Okay,
the
Sam,
urgency.
it's okay. We are here to help you, and I am
I
Dr.
know.
Riazat,
Yes.
and
Okay.
I'm
Yes.
here as a
Just
GP
1 second,
for you.
doctor. Just have to take excuse from Mr. President. Mr. President, I'm just calling you in 5 minutes. So just hang on for a minute. I know the urgency of the
Okay, no
situation.
problem. I can see that you look very sad, and I feel very sorry for that. Uh, but I want to show that I'm here to help you, and I share that you can talk and what's making you upset. I'll try my best to show you the right decision and the right direction. And Sam and I will be here with you unless you are ready to talk.
Yeah, what's going
Okay,
on,
Sam?
doctor? I just asked you that I had to just talk to the president, and you just started talking. It's very urgent because the world is at stake. You don't understand what's going on. The world is at work. It's gonna destroy, everything is gonna be destroyed. The nuclear explosion
Sam.
is near, and the only I am the scientist who is left alive, who can break this code. So you
Okay,
have to
Sam, I
let me
can.
go. You have to let me go. Otherwise, there is no tomorrow.
Okay, Sam, I can understand that you are very worried, and it's okay. We are here to help you. And Sam, how is your mood in these days? What's going on? You can tell very openly.
I'm just I'm very anxious. I just have to be there right now. In 30 minutes, I have to go.
Okay, Sam. Like what's the time? Like from how long you are having these kind of anxiety or something behavior?
It's been growing for the last 3 months, but now there is no time.
Okay, Sam. Like how is your sleep nowadays and appetite? Is it okay? You're sleeping well, or it's disturbing at the night?
I can't sleep, doc. This is not the time of sleeping. I'm not sleeping for the last 5 nights, and I don't need to. I have to stop this. I am the only one who can stop it.
Okay. Is there any nightmare at sleep or overnight? Is there any nightmare?
No, I'm not sleeping at
Okay.
all. From where the nightmare will come?
Okay. Okay. Did you have some do you think that the life is worth living?
Yes, definitely. I have to live, otherwise everyone will be dead.
Okay, Sam. Do you think that somebody is harming yourself and you want to harm yourself? Is there any thinking about that?
No one can harm me. The president said that he has got protection for me.
Okay. Is there any definite plans in your mind for suicide? Any previous attempts?
No, definitely not. I'm going to save the world.
Okay. Okay, Sam. I want to ask some strange questions. Are you okay with that?
Yeah.
Okay. Did you see or hear or feel things like others do not?
Yeah, I can hear president talking. Can't you hear president is talking? He's just beside you. I can hear him. You can't hear anything?
Okay, I can feel that you are hearing some voices over there. Okay, Sam, do you think that someone is spying on you or trying to harm yourself? Do you?
No, I don't think anyone is spying on
Uh,
me.
okay. So, Sam, do you think that someone is following you?
No.
Do you think that the people are talking about you?
Yeah, everyone is talking about me because they know that I am the only person who can
Okay,
stop this.
okay, okay, that's good. Do you think that or feel that you are feeling guilt or having any guilty about something?
I'm not guilty about anything.
Do you think that you have some special powers, like somebody controlling you,
You tell
or you can
me,
control
don't
the
you think
world?
I don't you think I have the power to stop these things that's gonna destroy our world?
Yes, I can see that you have some powers you're talking about. Okay, do you think that someone inserting or withdrawing parts from your mind?
No, no one can do that.
Okay, Sam. Do you think that you need medical help?
No, I don't need any help. I think everyone needs help from me.
Okay. Okay, Sam. There is a fire in this room. What you will do?
Is there a fire in this room?
Yes. If there is any fire in this room, what you will do?
I will do something to stop it because I can stop fire.
Okay, Sam, that's good. Did you know that what's the time and the date is today?
No, I just don't have those things. I'm just there's a lot of things in my mind, doctor. I
Okay.
can't remember anything like this.
And can you say that who am I?
You're the doctor?
Okay. Okay, Sam, that's good. And can you explain about your home situation and any pets at home or at your work?
There is no one at my home. They don't understand me, so I just left them.
Okay. Do you use some any recreational or illicit drugs nowadays or in the previous time?
No, I have to be clean.
Okay. Do you smoke or drink?
No,
Okay. Any allergies or any medical history or any medical illness in the previous?
no,
Okay. Do you have some any flu-like illness in the last few days?
no.
Okay, Sam, thank you very much for your all information and everything you have shared with me. Please excuse me for a bit of time and I will go to my examiner and again come to you. Okay?
Okay.
Dear examiner, I would like to present a mental state examination of a patient who is 35 years old, Sam, and he is a male and uh, he dressed well and he's very, his cooperation is not up to the mark and he's not maintaining an eye contact and his the posture is a little bit stooped and sometimes he is fidgeting and a little bit restless and agitated sometimes. And he's all the time was responding to the unseen stimuli and his speech was a little bit rapid and pressurized and he was not answering properly to the question, but sometimes he answers very nicely, but sometimes he's like he's in the hurry.
I'm
And
up. Okay. All right, time is up, Dr. Riyajat, but you can just continue. Let's see what we can find out from here. Yeah.
okay, and in emotions, like he was anxious and converting to the mood, and he was hallucinating, and he already all the time he was explaining that he can see and he has some magical power or he can hear some voices from the president. And thought form was understandable and linear. And sometimes he got managed, and sometimes he was explaining about delusional speech, and insight was okay, and cognition and judgment was normal, and he was a little bit at first because he was in very hurry and his repo was okay and reliability as I think we have to get some collateral history uh, from the other members of the family. And he was not using any drugs or something like that. And so he has no any history of medical illnesses, and so he was not using any recreational drugs.
All right. All right. Thank you, Dr. Riyajat. I just don't know, like I couldn't hear you properly just during this MSc presentation. It could be because of the issue with the microphone that you're using. But yeah, you did really good with the history. But I think like a few things that we can add in the MSc presentation. So I'm just going to
Okay.
ask someone else. to see if you guys can do a MSc presentation based on what we discussed now. So not the history, just the MSc presentation.
Yes, can I do, doctor?
Yes, Jaina, go on.
Yeah. So I'm presenting MSE of patient Sam. He is 20 years old, brought by parents due to change in behavior. In terms of appearance, he is well dressed, well groomed. In terms of behavior, he was distracted due to respond to unseen stimuli. He was cooperative with me, but it was also distracted because he was talking and seeing unseen stimuli. In terms of eye contact, it was not able. He was not able to maintain eye contact. His speech was a pressure speech, and in terms of tone, it was in a pressure, and the volume was, in terms of volume and rate, it was a pressure speech in both rate, tone, and volume. In terms of emotion, because the mood he was seeing, like was not assessed properly. The mood was not assessed properly. In terms of perception, he was having auditory and visual hallucination as he was talking to someone during the whole conversation, and he thought, I am very like I have a special power. I'm calling the prime minister. There is there is atomic bomb, and I need to save the world. In terms of thought forms, it was loss of association, so kinds of tangentiality. In terms of content, there was a delusion of reference and delusion of a grandiosity and a persecutory delusion as well. His insight was impaired, okay, because he doesn't want any help. In terms of risk, there is no risk of suicidal or homicidal agitation, okay, but he is at high risk because of hallucination and delusion. His rapport was not well built with me and reliable. I need a collateral history from a parent, and this patient is at high risk of himself and to others. Thank you.
Thank you, Joanna. Very good. Very good. Now, let's see what we have got in here. So, first of all, in the history, we also need to be sure, like, let's not assume that this patient can see the president. He might be talking to the president over the phone, right? Or he might be just hearing the voices. So we need to explicitly ask in the history that I know that you are hearing the president, you're talking to the president, but are you able to see him as well? In that way, you can be sure that yes, this patient has got both auditory and visual hallucination. So make sure always ask it, do not assume anything. And why do we think this patient has got a persecutory delusion, Jaina? Because when
Yeah.
it was asked
Mhm.
that it said like, is there anyone who is spying on you or trying to harm you? We said no. So if we say no, then the patient doesn't have any persecutory delusion. Okay. But you are right that this patient has delusion of reference because people is talking about him, and delusion of grandiosity because definitely all over the conversation he was showing that, right?
But
So
Dr. Ashan, he told, do you see the prime minister? He has a visual hallucination. What do you think? He told, don't you see the prime minister is?
yeah, I know, like that was this thing, right? So don't you see the prime minister? So
Yeah.
don't you see the president? So that can be enough to say that he has visual hallucination, but it's always a good idea to just ask that can you see the president here? It just confirms things. Sometimes during those role play sessions, a
Yeah.
lot of small tiny details will be missed because a lot of things happening, a lot of information you are getting, but this is a very important information. So anything that is under the aseptic J3R, especially the hallucination and delusion, confirm it that yes, can you see him? Can you see him here? So that will be a good idea. But if throughout the conversation you see that he's talking like he's definitely seeing someone, he's just looking around the room, he's talking to the president, yes, then you can gather that information from him. But it's always a good idea to ask.
Yes, sure.
Okay. All right. Now, what else we can add here? So appearance, behavior, so speech. So speech in here, sometimes it was pressured speech. That's right. Sometimes he was a bit loud in volume. the tone was okay, and we already said that it was a rapid pressured speech sometimes, but not the full conversation. Emotion in this case, the patient said that I feel worried or something like that. So whatever patient says after emotion, you can just tell that. And the affect was congruent. He looked worried. Perception, we know both auditory, visual. Thought form, there was no loosening of association here. Remember one thing, that just because we are thinking about psychotic patient here doesn't mean that they will always have loosening of association. Loosening of association ideally will never be given in the exam because you will not be able to gather any information from that patient. So loosening of association means anything patient is saying to you, you can't understand anything. He just keeps on rambling and rambling, and there is no point of talking to the patient. That's loosening of association. Okay, so most of the time you'll never get a loosening of association in exam. Okay, then thought content, this
So it was
patient,
linear, Dr. Ashan. It was
yeah,
linear here? Yeah.
yeah, linear.
Okay.
Thought from linear is okay in here. Delusion of reference was there, delusion of grandiosity was there, but there was no persecutory delusion or any other delusion. Insight was poor. Cognition, patient was oriented to the person, but not to the time. Judgment was poor. Risk, this patient is a moderate to high risk because of the active hallucination and delusion. Then rapport, you can say that, yeah, you were not able to maintain a good rapport in this patient. And the reliability, it is not reliable. So you'll need to take some collateral history from the parents, okay? Because that's parents actually brought her in. So you need to take a collateral from the parents as well. Tangential speech, Syra, is a type of loosening of association. Tangentiality means like you asked a question, what's your name? Patient did not answer that question, but kept on saying so many things, and still at the end of 2 minutes, still he or she did not mention the name that you asked. So it's about talking things that is not relevant, and there is no association between each sentence patient is talking about, which in an active schizophrenia patient, many times in real life, we see that. When we get a active schizophrenia patient, they don't make any sense. They just keep on talking and talking, and you will find it very difficult to get anything out of them. That's loosening of association. But ideally in exam, they can't give those kind of patients because then there will be nothing that you can get from that. Okay, so usually you don't get it, but loosening of association, you will know that this is loosening of association because there is nothing relevant in that speech. Okay. Now,
What
one
was
thing,
this
yes,
is Dr.
ask.
Ashan. This is schizophrenia or manic patient? Schizophrenia, yes?
This is actually difficult to say that what is this patient because we haven't asked the mania questions in this patient in detail. So as part of what we can gather, delusion of reference, delusion of grandiosity, this will be more as a schizophrenia patient, just not a mania patient. Okay, so we to say mania, there are some specific feature that we need to find out, which will be patient mood will be euphoric, then patient speech will be rapid pressure that we got. Patient will be involving himself or herself in lots of risk taking behaviors like the dig fast. That's right. So there are a lot of things that we try to find out. They will not sleep because they don't feel the need of sleep. They will be excessively energetic. Okay, so those kind of things will be there. And if it was a diagnosis and differential diagnosis case, then definitely we would add dig fast in this case to rule out mania. But given it is not a diagnosis differential, we did not bother about it. But as part of what we have got, this is most likely to be a schizophrenia patient than just a mania.
But
One question.
Because you don't get auditory hallucination in a mania patient. Okay?
So because you didn't get auditor hallucination, you exclude mania, but he is disorganized speech, inappropriate, grandiosity,
Yeah.
the minister he has like that. He's speaking pressure and fast, absence of sleep, yes, and
There,
thought is, yeah.
there are a few things that we can say that goes side by side with mania. But how to exclude mania? Mania definitely will not have hallucination. Hallucination is not a part of mania diagnosis. That's one thing. But now, schizo can have delusion of grandiosity, like the case that we have done in the trial class. Patient was thinking, I am the messenger of God. That was also a delusion of grandiosity, but that was a case of schizophrenia. So, just because of delusion of grandiosity, it's not just mania. Rapid pressure speech can be there in a schizo patient as well. It's not always that it has to be in mania patient. To be mania, they has to have those specific features, and also they definitely don't have hallucination. So this can be tricky to diagnose, but you can easily rule out mania as your number one diagnosis when they got hallucination.
Okay, and
Once,
yes, please ask. Yeah, thank you very much.
no, that's fine. It's one small question. What about bizarre delusion? Is it like how to differentiate it with like grandiose delusions? Because these things, what he said was also like unrealistic. So,
Yeah. So these delusions that schizo patient gets, those are bizarre. Bizarre means which doesn't have any sense. Like the things that you can't make any sense, that's bizarre, which we get in a schizophrenia patient. Whereas non-bizarre delusion, which you can get in a delusional disorder patient, non-bizarre sometimes still they have a little bit of sense. Like maybe it can happen. Like patient has a headache and patient thinks that he or she has got like brain tumor, and he, even if you do everything, he still thinks that he might have a brain tumor. Or sometimes, now that's usually we would say more as illness anxiety disorder or hypochondriasis. As part of non-bizarre delusion, you can say that patient believes that he or she has got brain worms in her brain. Now, worms in the brain, it's delusion. But can it happen? It can. Very rarely, but yes, it can. I believe that I can't see because there is a worm in my eye. It's unlikely, but can it happen? Yes, there is a rare possibility it can. So the non-bizarre are those delusion, which is still there is slightest possibility it can happen, and the bizarre is completely nonsense. So that's how we can differentiate bizarre and non-bizarre. But definitely in this patient, the thoughts that this patient having, those are like those will be bizarre delusion, because this is not, definitely he's not the person who knows the nuclear code and world is going to be destroyed tomorrow. Okay, so you get bizarre delusion in schizo, and non-bizarre you get in just a delusional disorder. But that's not how we mention delusion in the exam, because all the delusions that we get in a schizo patient, those are usually bizarre delusion. But what type of delusion those are, that's what we usually mention in the exam. Is it a delusion of reference? Is it a delusion of grandiosity? Those things will be mentioned. Okay?
thank you.
Hello, sir.
Yeah.
Sir, in this scenario, when we just started taking history, the patient started talking very loudly, and he was not letting us to
Yeah.
complete the history or something like that. So, how to tackle this situation?
That's the thing. I was just going to say that, like the approach that you had in that case, I would like to change that approach a little bit. So,
Okay.
because let the patient talk at least 15 to 20 seconds if he's doing that, because you can't interrupt in between. Now, if like I did not take even 10 seconds to talk about what's going on, I just now sometimes these are important context of the case. If you don't hear them out, you might miss the main thing. Okay, so here the main part. So what you could see initially, the patient was talking to a president and talking about end of war and some kind of explosions, some kind of things. So you got that idea what this case is all about, right? Hear it. Now, if you stop the patient immediately after he has started talking, likely chance he will not even talk about it, or he will get annoyed. So, and it's not a good approach. So, what I would advise that let the patient talk until you want to hear what's happening. Once you find out that this is just becoming nonsense and things are just getting repeated, and then interrupt the patient. Say that, Sam or John, I understand that there is something distressful going on. I'm so sorry that it's happening with you, but please have a seat here. If patient is standing, please have a seat here. I'm just going to ask you a few questions about what's really making you distressed, and I'll try my best to help you in this. Then patient can say, I know that this is real, you don't know this is very urgent, I have to go. You'll say, I understand how urgent it must be, but John, please have a seat for 10 minutes with me. Let me hear you out, and definitely I'm going to help you with whatever urgent situation is going on. I want you to know that this is a safe space. You can talk to me about any urgency or any situation that you are in, and these are confidential between you and me. So you have to also use your own way of talking it out. There is no hard and fast rule of this kind of things because every scenario in the exam will be different. You just do the best, but do not interrupt the patient. And because how you interrupted the patient, it meant that you don't want to hear him out and you just here to pass the exam because you know that the time is running out. You can't let the examiner know about it. Definitely in our mind, that is the case going on. And I want to pass this exam. I want to finish it in time. But the way that we will be doing that, we will not show it to the examiner. Okay, which means that that's the time it comes your empathy to the patient, the respect to the patient. That yes, I'm hearing him out, but as soon as he started making it a bit nonsense, I interrupted him. That's okay. But do not interrupt the patient just immediately. Okay? And hear him out always. If he, in the middle of conversation, sometimes psychiatric patients start talking to someone as if that he or she is hearing someone. So do not just say that, come down, don't talk to anyone else. Talk to me. Don't say anything like that. Just listen to the patient, find out what's happening because sometimes they try to give positive findings through these kind of things. Okay? Okay, thank you. Any questions on this case, guys? And yes, the tangentiality means patient will never answer your questions. Circumstantiality means patient will eventually, after rambling a lot of things, he or she will come back to the come back and answer your questions. That's why we call it circumstantiality, like a circle. So you asked the questions, he talked everything he wants to talk, and then at the end he answered your question.
Yes, doc. How will you present this patient to the examiner?
Yeah, okay.
Yeah, the ideal one. Yeah.
All right, we can say in this way, we can say like, hi, dear examiner, I would like to present mental state examination of my patient John, who is brought in by his parents due to change in behavior. In terms of appearance and behavior, he is well groomed. He was not maintaining eye contact at times because he was responding to some unseen stimuli. He was cooperative sometimes, but most of the time he was a bit restless and not cooperative. He he was not showing any restlessness or agitation. Sorry, there is a bit of a noise happening. Sorry, I'll just mute the. Okay. So that's appearance. As part of his speech, he was having rapid pressure speech, but no disorganized speech. His emotion, he mentioned he was a bit worried, and the affect that I have observed is congruent to his mood. He was having visual and auditory hallucination because he mentioned he can see and also hear the president. Thought form was linear. As part of thought content, he was having delusion of grandiosity because he believes he needs to go and see the president because he's the only person who can stop the imminent war and explosion and destruction of the world. He was also having delusion of reference because he believes people are talking about him, and his insight was not intact. He was oriented to the person, but not to the time or place. And his judgment was poor. He is high risk because of active hallucination and delusion. I was not able to maintain a good rapport with my patient. And the history is not reliable, so I would like to take collateral history from his parents. Okay, so it's nice and easy. You just talk about what you find.
Thank you so much.
Thank you. Who wants to do the next role play?
Doctor, I would like to try.
Dr. Rita, very good. Okay, give me just one moment. All right, Dr. Rita, so this is your case. You have got 1 minute time, and after 1 minute, we'll start.
All right. Doctor, I would like to start.
Okay, just 1 second. So this is your patient, Sarah. You can start.
Hello, good morning. I'm Rida and I'll be looking after today. Can I please confirm your name?
I'm Sarah.
Sarah, nice to meet you today. So how can I help you?
Um, I don't need any help. I just need to get the refill of this lithium, please.
All right, Sarah, thank you so much for letting me know. And let me show you that I'm here to help you out. And I appreciate that you came here for the follow-up and getting your medicines back. And I just want to let you know that whatever we discuss today will stay confidential. This is an open and safe place for you. All right?
Sure.
Can you please tell me why you need the refill?
I just ran out of it.
What are you taking?
Lithium.
All right. I can see from the notes that you have been diagnosed with bipolar disorder. Since when?
It's been 3 years.
All right. And have you been taking your medication regularly as advised by the doctor?
Sometimes I miss it, but yeah, mostly.
All right. And anytime do you feel like you're really, your mood is really feel like top of the world, really high, happy, energetic?
It's been a while. It hasn't happened after lithium.
All right, that's great. And other than that, any times you feel really low or sad?
Yeah, it's just been very difficult.
Okay, since when are you feeling so?
Last 1 month.
All right. And anything happened after that this happened?
I just don't want to leave anymore because it's just too much for me.
I'm so sorry. Can you tell me what exactly happened that you're feeling so sad and these thoughts are coming to you?
I killed a patient. I'm the murderer.
All right. And do you have any previous attempts of harming yourself?
No,
Any new plans you have made?
no.
Any access to any weapons?
I'm a nurse, so I have some access to some drugs.
All right. And have you by any chance decided a date so far?
No,
All right. Can you tell me what did the coroner say about the death of the patient?
say that it was natural. There's nothing can be done, but I know they just want to save me. I know
All
it was
right.
my fault.
All right. And do you have any active ideas at the moment of harming yourself or somebody around you?
Yeah, I just want to
All right.
take some pills.
All right. Other than that, can you tell me, do you have any strange thoughts and behaviors that other people find strange?
I don't know. What do you mean?
Like you hear something, see something, or feel something that other people don't?
I can hear everyone is talking in behind that I am the
All
murderer.
all right. And do you see them as well?
No, I just know that they're talking behind me.
All right. And do you hear these voices only when you feel low or all the time?
I don't know. It's just strange. I can't see them. I can't. I just feel like they are talking behind me. It's
All
just
right.
strange thoughts.
All right. And do you feel guilty about what happened with the patient?
No, I know I am the guilty. I should be hanged for murder.
All right. Do you feel you have any special powers?
No,
All right. You think people are trying to harm you?
no, I wish.
All right. Do you think people are putting thoughts in your mind, are taking the thoughts out of your mind?
No,
All right. Do you think you need medical help?
no. I just want to stop.
All right. Just a hypothetical question, Sarah. I ask all of my patients. If there's a fire in this room, what will you do?
I think that would be a good way to go.
All right. And do you know what time is it at the moment?
No,
Where you are?
in the clinic,
And who am I?
doctor.
All right. Thank you, Sarah. Thank you for the cooperation. I'll come back to a refill of the lithium as soon as possible. I just need to have a discussion with the examiner. Is that okay with you?
Yeah.
All right, thank you. So, examiner, I would like to present the mental state examination of my patient, 30-year-old Sarah, who presented here for the refill of lithium. On appearance, she was well dressed, appropriate to the weather, well groomed. She was not maintaining eye contact, and her facial expressions were teary, and posture was stooped. And I could not see any evidence of alcohol or drug abuse on behavior. She was overall cooperative. I could not see any abnormal behavior, like any tics, any tremors, or any psychomotor agitation. On speech, the rate was low, volume was low, quality was clear. I assessed the mood, and according to her mood, she was feeling low and sad. And the mood, the effect I observed was congruent with the mood. On perception, she has auditory hallucinations, although there are no visual or tactile hallucinations. On thought form, there was some poverty of ideas and thought content. I could see that she had delusion of reference, delusion of guilty. And her risk assessment, she is at high risk because she have active ideas of harming herself, and she also have access to the pills as well, as she's a nurse. His insight is impaired, judgment is impaired, and or she's on cognition, she's alert but disoriented to time, but oriented to place and person. Regarding the management, coming back to Sarah, thanks so much for waiting and cooperating with me. So, Sarah, I know that you're here for the lithium, and but I can see that you do have an active ideas of harming yourself. So I would like you to be admitted here. I will like you to stay here with us in the hospital. You will be seen by a crisis assessment team, which includes a couple of psychologists, psychiatrists, and mental health nurses. They will assess you, and if they think that you are safe to be discharged, you will be discharged with community treatment. But at the moment, I can see that you have active ideas of harming yourself. So most likely they will admit you and they will start you on some mood stabilizers, the lithium that you were taking. Other than that, they might also consider starting on some antipsychotics as well. With time, we will gradually taper down the antipsychotic dose, but we'll continue and discharge you with the lithium, and we'll regularly monitor you with lithium level as well as thyroid. How does it sound to you?
Oh, good, doctor. Thank you.
All right.
Thanks a lot,
Thank
Dr.
you.
Rita. You did really good. I'm happy with how you presented the case. It's brilliant. Okay. So
Thank you.
what we can find out from the history was pretty good, but I want you to show some empathy in your voice. And sometimes we mean well. Sometimes we say everything right. We say that, yes, I'm so sad to hear, but we also have to show that with our change of the voice. So when you see that the patient is talking a bit slowly, a bit sad in front of you, you just start changing your tone of the voice and try to show that empathy that this patient needs from you. So say that, Sarah, I can see that something is bothering you. You look very sad, and I know that you're here for lithium, and I'm going to give the script to you, but I would like to ask a few questions about your mood, and I want to make sure you're okay. I want you to know that this is a safe space. You can talk about anything that's happening with you. I'm here to help, Sarah.
All
So,
right.
okay, see that the change of voice, that's when we know that you are actually sad for this patient. It's not just a regular patient that comes to you and you are done with the patient and you want to see the next patient. It cannot be like that. In real life, also the same thing. You show, because when a patient comes to us and share these things with us, maybe even their partner doesn't know about this, you know it. So sometimes you are the point of contact where they are very vulnerable, it's very sensitive, especially the psychiatric topics. When they share something very sad with you, you have to show that with your voice, with your posture, your tone. It has to change. And as an examiner, that's what everyone will look for. An examiner looks for this kind of criteria in a candidate when they wants to pass a candidate. So I always say that the first time candidates, because they know things, because when we take the course has everything to pass, but still I see the candidates fail, because that's where I think candidate get it wrong, because they're just in a very, very nervous state. They want to finish the case in time. So, and they want to show that they are very confident, but when they try to do that, sometimes they forget the main thing of the case. The main part of this case in a depressed patient is the empathy from a doctor. Okay, so you have to show that anyway, right?
All right. Thank you.
Okay, now the other thing in this case, so the history was pretty good. The If we have time, we could ask about lithium a little bit more, but it's not necessary in here. So because you already talking about the MSc presentation, you asked most of the important questions like how long you're taking it, are you taking it regularly? All those things are important in here. So whatever in the STEM, do not forget that. Do not just stick to the format always. The format is there so that you don't miss important things. but you have to change it a little bit according to the case. This patient is a known bipolar disorder and on lithium, and the patient actually came for a refill of the lithium. You don't know anything about the patient, so you have to ask a little bit about the lithium, just like Dr. Rida has done, and it's for everyone. You have to ask about lithium, how you're feeling, so those things will come. After that, you go on with your mood, sleep, appetite, all the questions, and everything was nice and good in the history. As part of MSc presentation, appearance good, speech in here, it's not just slow, we would also say it was slow monotonous speech, and patient was taking pauses in between. Try to include some negative findings if your time permits. If time doesn't permit, especially for 3 tasks, you will not be able to include the negative things. So, but if time permits and there is only 2 tasks, try to say some negative findings also. Like there was no disorganized speech, there was no rapid pressure speech. Emotion, yes, patient was saying that emotion is low and the affect is congruent. Perception, was this patient having auditory hallucination? What is the difference between auditory hallucination and delusion of reference? And during the history, we found that I say that I can't actually, it's an unusual thought. I can't hear them, I can't see them, but I know that they're talking behind me. What's that? That's not auditory hallucination. So sometimes this kind of confusion happens, especially between these things. These are very, very tiny little details. We will know if you are not sure that this is an auditory hallucination or is this a delusion of reference. You try to find out more. You try to ask some more questions to be sure that are you able to hear any voices of those people that's talking behind you? Can you hear them talk? Can you actually hear their voices? When you say that line, then patient will say, I can't. I think I can't even hear them, but I know that they're talking behind me. So when that's the case, I can't see them, I can't hear their voices also, but I know that they're talking behind me. That's the time we will not think it as auditory hallucination. Instead of that, it will be delusion of reference. Okay, so these two usually gets commonly confused, and you are not wrong to confuse this up. So please make sure that when you are not sure, is this patient actually hearing the voices or is this just people talking behind him? Ask that, can you actually hear their voices? So that's the time you will get your answer. Okay. Thought form was linear. You can say there was some poverty of thought. Thought content, in this patient, the thought content the patient was having is delusion of guilt, definitely. And patient was having delusion of reference. Is there any other thought content we can add here, guys?
So can we add the persecutory as well? Because she did mention that she wanted to harm herself because she harmed someone else.
No, this one is different. Persecutory delusion is when patient thinks that someone is spying on them, someone is trying to harm them. So it will not be that. But you are right, the thought content will be suicidal thought. So suicidal thought is a thought content. Suicidal, homicidal, those part you will need to also add here. So along with the delusion of reference, delusion of guilt, also you will say that he was also having suicidal thought because that's a thought content. Okay.
Thank you.
Thank you. Now, insight was poor, judgment was poor, cognition, yes, some of the cognition was there. This patient is a high risk given this patient is having active suicidal thought and also some delusion. Patient was able, you were able to maintain a good rapport, and the history seems to be reliable, right? Now, when we talk about initial management in this patient, sometimes they do add those kind of tasks in the exam. What is the diagnosis of this patient? This is definitely not mania, but we know it is a bipolar disorder. So the diagnosis is bipolar depression. So at the moment, patient having a bipolar depression, right? So you'll need to just say the name of the diagnosis. So say that, Sarah, thank you so much for all the information. From the history, it seems like that you are going through the bipolar depression at the moment because you are very sad. You're having difficulty with your sleep and appetite. You have self-harming thoughts. And I'm so sorry that you are feeling this way. Sarah, at the moment, given the high risk situation you are in, I need to admit you to the hospital, and I'm going to call my senior who will also come and talk to you. In the meantime, I'm going to involve the acute mental health team, which is comprised of a psychiatrist, a psychologist, and mental health nurse. They will come and assess you, and if they think that you need to be admitted in their unit, they will admit you in the psychiatric unit for active management of the situation. While we wait for them to come and see you, I'll also take some blood and I will check for your blood count, inflammatory marker, thyroid function, lithium level, just to rule out some organic issues that might also mimic with this. So we always do an organic workup in this kind of patient. The psychiatrist, based on your symptoms and severity, definitely they will continue the lithium to stabilize you, but also they will most likely start you with a short course of antidepressant until your depression gets better. So you know that how we treat the bipolar depression. Bipolar depression, we don't give antipsychotic. This patient is already on a mood stabilizer, which is lithium. So we just add the antidepressant. So any SSRI, plus we will continue the lithium as the patient is already on it. If the patient was not on lithium, then we could add lithium, antipsychotics. We could add any mood stabilizers like carbamazepine, anything. So, but at the moment, because of the depression, we need to add a SSRI in this patient. We know that in a bipolar depression, if we only give SSRI, that will actually exacerbate the possibility of having a manic attack. So patient is already on a mood stabilizer, so we don't need to worry about that. We just need to add a SSRI in this patient. Okay. Any questions, guys?
One question, since the patient is having psychotic symptoms, don't we need to add any antipsychotics for this?
Good question. So what usually happen that first you try the antidepressant, see how the patient goes, because sometimes it could be a part of severe depression, which is manifesting as those psychotic symptom, because sometimes patient can have both depression and psychosis together. So in this kind of patient, we can start SSRI first and see how they go. If SSRI is not helping, then we will definitely add an antipsychotic as well. So most of the time depends on how the patient responds. Most of the patient will start with the SSRI first to help with the depression, because the main part in here is depression. And together with that, many times depends on the patient's severity. We might need to add an antipsychotic later on as well. So sometimes patient will be on SSRI, antipsychotic, and lithium, three things together, but it will be one at a time.
Yeah, thank you. Thank you.
But very good question, Dr. Indumini.
Yeah, doctor, I wanted to ask, in this case, is it okay we ask about the history on the side effect of lithium?
We can. If we have time, then we should, but this case we will not have that much time. So even if you don't ask it, it is really fine. As long as you just mention that I know you are taking lithium, how long you are taking them, And are you taking it regularly? Have you got any side effect from them? So you can ask 4 or 5 questions that will be enough for this kind of case.
Okay, thank you, doctor.
Thank you. All right. So I think that's all that's we need to discuss in this case. So let's go on to another case. Who wants to do the role play?
Hello, doctor. Can I do it?
Yes, definitely. Dr. Bora?
Yes, doctor.
Yeah, okay. Give me just 1 minute.
Yeah.
Okay, so this will be our last case, most likely. Let's see if we can go into that.
Okay.
All right, Dr. Bora, this is your case. You have got 1 minute time.
Okay.
Yes, Dr. Saira, our course covers all the AMC clinical. We have surgery, pediatrics, everything in the course. That's right.
Doctor, can I start?
Yes, so so this is Amber. You can start.
Thank you, doctor. Hello, I'm one of the doctors today here in the ED department. May I just confirm your name and age, please?
Amber, 24-year-old.
Hello, Amber. Nice meeting you. So, Amber, whatever we are going to discuss today, it will be confidential in between us, and I am not going to disclose to anyone. So, don't feel ashamed or judged to share anything with me. So, today I am going to ask you a few questions before discharging you from the hospital. Is that all right with you, Amber?
Yeah, I just want to go home. It's been a long day, and I've been already cleared by the psychiatric team. They say that I'm okay to go. Why I have to talk to you guys again? Can't I just go
Great.
home?
Oh, that's great to know, dear Amber. And that is good that you are already stabilized and you are already ready to go home. But as a protocol, we are going to ask you a few questions, screening questions. We are going to ask you a short history so that you are safe to be released to home. Is that all right with you, Amber? Hope,
Yeah,
I
sure.
hope you will cooperate with me.
Yeah, sure.
Thank you so much. So Amber, can I know you regarding your, as from your medical notes, I came to know that you took some overdoses of tablet diazepam. So may I know the reason? What may be the reason?
Yeah, it's just like a silly thing to do, but I just had a fight with my boyfriend because I was not in the mood of talking to him.
So sorry to
And
know about that.
yeah, he was calling multiple times, just getting very clingy.
Mm-hmm.
And suddenly I just snapped. And
Okay.
I do this all the time. And then one thing led to another. We started fighting.
Mm-hmm.
And he he just ended up breaking up with me. So
Okay.
I just wanted to show him that how much I love him.
Sorry to know about that. So was it for the first time? Did you try it for the first time, or did you try it before also?
Yeah, I tried it before,
So how many times did you try it before, Amber?
like 10 times.
10 times. So this is for the first time you got admitted to the hospital?
Yeah.
Okay. So, Amber, along with this, did you try to harm yourself also, like in other forms? Did you ever try the other forms of harming, like cutting yourself or
Yeah, sometimes I
anything
cut
else?
myself to take away some stress.
Okay. So, other than harming yourself, do you have any ideas of harming others also?
No.
Do you feel that life is worth living?
Yeah, I do.
Okay. And I also wanted to know a few other questions. How is your mood these days before coming to the hospital?
I just feel very angry at the moment.
Yes, I can completely understand. Sorry to know about that. And how about your sleep and appetite these days before coming to the hospital?
It was good.
Okay. And I'm asking you a few screening questions. Do not be worried about these may sound a bit like a bit unusual questions, but these are some screening questions. Okay. So, do you see, feel, or hear things that others cannot?
No.
Okay. And do you think that someone is spying on you or trying to harm you?
That's not, I don't think so, but why he will just break up with me out of nowhere just because I got snapped? That's
Mm-hmm.
normal me. He knows about me. I just don't know. Like, I think he must be cheating with me.
Yes. Sorry to hear about that. And also, do you think that people are talking behind your back or they are trying to harm you?
No, I don't think so.
Okay. Do you also think that you have some special powers?
No, I don't have power, but I know that I'm the most perfect girl in the world. So I
Mm-hmm.
just don't know why he wants to break up with me. I'm such a beautiful person.
Yes, I can completely understand your reasoning. And do you feel that you need medical help?
No, why I would need medical help? I'm okay.
Okay. Suppose I am asking you an imaginary question, if there's a fire in this room, what you will do?
I'll just run away.
Okay. So where are you now, Amber?
Sorry,
Where are you now?
in the
Uh,
emergency
what
department.
what situation? In which situation? Okay. Can you just tell me the date and time of the day?
It's 11th of January,
Okay.
Sunday.
Thank you so much. Can you just tell me who am I?
The doctor.
Okay. Did you had any past medical history or any past history of any mental health issues?
No.
Okay. Are you addicted to any kind of recreational drugs, or do you smoke or drink alcohol regularly?
Yeah, I used some street drug and I had to go to jail a few times for that.
Okay, sorry to know about that. Thank you, Amber, for all the informations that you have given to me. And now I'm going to present the mental state examination of my patient Amber to my examiner. So first of all, regarding her appearance, I could not comment on her appearance as I cannot see the patient, but I believe that this patient will be a bit unkempt. She may be in a bit distress, and she may be a bit unsatisfied. And regarding our grooming and hygiene, I cannot comment because I cannot see the patient. And on examination, on the appearance, I could not see any evidence of self harm in this patient. Regarding her behavior, I believe that this kind of patient may have poor eye contact, and her facial expression, although I cannot comment on her facial expression, but this kind of patient may be anxious and kind of dissatisfied. And I cannot comment on her psychomotor agitation or any psychomotor retardation. And regarding building rapport with the patient, yes, I was able to build a good rapport with the patient because she was answering all my questions. Regarding her speech, regarding the rate of the speech, it was, I believe, it is normal. It was not loud. It was normal, and the fluency was also normal. Regarding her mood, I felt that her mood was normal for the time being at present, and regarding the effect, it was congruent with the mood. And regarding her thought, I believe that the thought is linear because it was in a logical order. but sometimes she was not that cooperative, and there were also, I believe, that loosening of associations were there, and speech was also kind of a bit restricted in between. And regarding the thought content, she has delusion of grandiosity because she told that she is perfect. She does not need any help from anyone. And I could not observe any overvalued ideas. And although she had the previous history of the suicidal thoughts, but at present I could not observe any suicidal or homicidal thoughts in her thinking during her presentation in the history. So only one positive finding of the delusion. Regarding the thought position, I could not see any history in the history regarding the thought insertion, withdrawal, or broadcasting. And regarding her perception, I could not find out any hallucinations like auditory hallucinations or visual or tactile hallucinations from the history. And regarding her cognition, she was well oriented to time, place, and person. There was no any memory loss. Regarding her insight and judgment, both are impaired. Insight was impaired because she thinks that she does not need any medical help. And regarding her judgment, I think judgment was normal for her. So regarding the risk assessment, yes, she has high risk behaviors because of her previous attempts, and also she also now believes that she has some delusions also. So these are some high risk behaviors are present. So according to me, the risk assessment for me would be moderate to severe risk still at present, although she was stabilized. So for me, the diagnosis for the patient, for this probable diagnosis for the patient may be bipolar, it may be borderline personality disorder, depending on our clinical presentations and the signs and symptoms from the history. Thank you, examiner.
Thank you. Okay. First of all, very good. Thank you, doctor. You did really good, Dr. Bora. So diagnosis was to the patient. So you have to give the diagnosis to the patient, not to the examiner. You ran out of time long ago, so you have to be a bit more quick.
Yeah.
But how you're doing the case, really good. Okay.
Thank you so much.
Now, a few things I want to add here. The way of starting the case, I want you to change it a little bit more.
Okay.
So like no one, even the examiners don't like that you start your statement with the confidentiality at first.
Okay.
Give the confidentiality statement just a little bit later after saying something nice. That makes it a little bit different from other candidates. So you can always say that, Amber, this is Dr. Bora. I'm one of the doctor in this emergency department. Very nice to meet you.
Yeah.
Amber, I know that you took 10 tablets of diazepam after having a fight with your boyfriend.
Yeah.
I'm so sorry to hear about that. It must be very stressful for you. But I know that you are stable at the moment and you want to go home, and I'm sure you will be fine. But I just want to make sure that it is safe enough for you to do so. So I
Yes.
want to take some. I want to talk. I want to ask you a few questions and make sure that everything is all right. I want you to know that this is confidential and everything is going to be between you and me unless it is harmful for you or others. So, Amber, if you could please tell me what really happened that has started all of this.
Yeah.
Okay, so that's how usually will be the best way to start. Instead of giving the confidentiality statement at first, do it slightly later. Start with building rapport first and then do that. Okay?
Okay, doctor.
All right. Now, other than that, when you have diagnosis as a task, and you know from the history that it could be borderline personality disorder, because how we know self-harming behavior multiple times, and with just fighting with the boyfriend, she has done that, but no suicidal thought. That's classic.
Okay.
Then she also went to jail multiple times for drug use. Second, right? If you ask a bit more questions, you will get all other findings. So when you know that this could be a BPD case, to come to the diagnosis, you have to fulfill those diagnostic questions. So what are the diagnostic questions for BPD? And DSM-5 criteria for BPD is patient will have frantic effort to avoid any real or imagined abandonment. So they don't like that someone is abandoning them.
Yeah.
but they also have unstable relationship because of their extreme anger,
Yes.
and they have this like frequent mood swings.
Yeah.
They also have identity disturbance, so persistently unstable self-image or sense of self, which means that they actually find it very hard to know who they are. Sometimes they are really good, sometimes they just lose it. So they
Yes.
have this sense of unstable self-image.
Yeah.
They're quite impulsive, so they will spend a lot, have sex with unknown people,
Yeah.
substance abuse, reckless driving, binge eating. So there are some of the impulsive finding that you will ask.
Okay. So,
Recurrent, yeah.
sorry to interrupt in between. So, doctor, like while exploring the history, suppose if the BPD comes into my mind, so in that case, before asking the other questions of the psychosocial history, I'll try to explore all these points, positive points in the history, so that I can come to a diagnosis.
Yeah.
I have to explore all these points in the history regarding.
Yes. So during that's the time. So mood, sleep, and appetite, suicidal thought.
Yeah.
During that questionnaires, you can add questions if diagnosis is a task. Like if it is a mania case, you have to ask mania questions. If it is a depression case, you have to add depression questions. Only if the task is diagnosis and differential, then we do that. Otherwise, we don't do that. Okay?
Okay, doctor.
All right. So we were talking about the DSM-5 criteria. So affective instability, which is the mood swings, chronic empty feeling, inappropriate anger, and they have this paranoid ideation. So you missed this point.
Yes, doctor.
Some of these patients can have paranoid ideation.
Yes.
Some BPD patient even can have psychosis during active attack, and they can have severe dissociative symptom. So what are these? This patient said that out of nowhere, he just ended up breaking up with me.
Yeah.
I think that he must be cheating on me. So that's called suspiciousness, right?
Yeah.
So patient, if you ask the patient, so you have to know that is it a delusion of paranoid, or is it a delusion of persecution,
Yeah.
or is it just a paranoid ideation? The
Okay.
ideation means when patient is not sure. So you will ask that, so do you strongly believe that he is cheating on you?
Yeah.
If patient says that, no, I don't know, I just don't understand. So see that this is what patient said.
Yeah.
So, but I think he has got someone else. He must be cheating with me. Otherwise, why he wants to break up? I am the most perfect girl in the world. So you got it right. This patient has a delusion of grandiosity.
Yeah.
But we asked, do you strongly believe that he is cheating?
Yeah.
Patients say, I'm not sure. I know he loves me. What else can it be? So this is where she's not sure. That's just idea that he might be, she is being suspicious during the active BPD moment. So that's one of the finding as well,
So
which
actually,
is
doctor, at this
transient.
point, I just thought whether I should mention this as paranoid delusion or persecutory delusion. I did not have the idea that I could have mentioned it as paranoid ideation or something like
Yes,
that.
now you know.
Yeah,
So
okay,
that's
doctor.
the thing. So sometimes we just need to say, especially for BPD, it's a common findings given in the exam.
Yeah.
So they can give you this paranoid ideation. But definitely we make sure to ask specifically to rule out it's not a delusion. So if patient say, yes, I'm sure, like, I'm sure that he has cheating on me, then yes. Then you still need to ask how you are sure. Have you seen him cheating with someone? Have you found something? Patient will still say, no, I haven't, but I know for sure that he is cheating. So that's when we know it could be a delusion. Okay.
Okay, doctor. Okay.
All right. So these questions we ask like this. So these are the diagnostic questions which we will add because diagnosis is here. So do you do anything else to ensure he does not leave you? Because she has this fear of abandonment. Okay. Did you have any other past relationship? If yes, how many? What happened with those relationship? How did they end? That's unstable relations.
Yeah.
How do you feel about yourself? That's the problem with the self-image. Any impulsive behavior like reckless driving, excessive spending, drug use, frequent mood swings. Do you lose your temper easily? Do you always feel empty or alone? Okay. Do you harm yourself to cope up with the stress?
Yeah.
So these are the classic questions which we need to ask. If you can't ask all of them, at least few of them you need to ask to come to the diagnosis.
Yes, doctor.
Okay.
Yeah.
So that's here. So you just need to say it's borderline personality disorder
Yeah.
and just say what is that? It's a mental health condition where patients have difficulty to manage their emotions and relationships,
Yeah.
often leading to self-harming behavior, marked impulsivity, and fear of abandonment. So that's only thing we will explain. There is a BPD case that we discuss in our other psychiatric classes.
Yes, doctor.
There we will talk about the management and other things. Okay.
Okay. So, doctor, like we can explain to the patient like this,
Yeah.
what is BPD?
Yeah, you
Okay.
can. Yeah, so patient, most of the time diagnosis will be to the patient,
Yeah.
but sometimes it could be examiner. If it is examiner, then you just mention that it is borderline personality disorder where patient have, then you can give some more medical jargon.
Yes. Okay, doctor.
Okay.
Yeah. Thank you, doctor, for the detailed feedback, and thank you for giving me an opportunity to participate. Thank you.
That's all good. Thank you. All right. Now, before we finish, I think we just did not do one thing, which is really important before we finish the MSc cages, MSc video. So I want any of you to do a MSc video case before we finish today. Anyone who wants to do that? Anyone who wants to just like watch the video and give the findings of the MSc? It's very easy. And in between that, RM, please edit. Yes, After you want to do that?
Yeah. Can I try?
Yeah, definitely. Anyone can try. So this is your case. When you have finished reading it, then I will start the video. Okay.
Yes, I'm done reading.
Okay. So once we finish the video, you will need to just give them MSc findings. Okay.
Hi Andy, do you want to come on in and have a seat? I'm Dr. Taylor, I'm the on-call psychiatrist for this afternoon. I got a call this morning from your family doctor because I think you went to see him this morning along with your mum, and I gather that things have been a little bit difficult for you. You've had some rather distressing experiences. So I think your doctor thought it might be helpful for us to have a bit of a discussion about that to see if I could help. Would that be all right with you?
No, it's fine.
Would it be all right, Andy, for you to tell me a little bit about what's been going on?
Well, you're going to think it sounds stupid, but my housemates are working for MI5.
Right.
And they're doing stuff to my brain.
Okay.
And they're out to get me.
Okay, that must be very difficult for you.
Okay.
How long has this been going on for, Andy?
About 2 months.
Right. And how did you first work out that this is what was happening?
I came home one time and they moved the TV to the other side of the room,
Right.
and I knew then.
And what was it that you knew at that moment?
That they were for MI5.
Right. Okay. Okay. So it's been going on a couple of months.
Yeah, this new lecturer started at uni,
Right.
and he works for MI5. And
Right.
he basically drafted my housemates in, turned them
Okay.
against me.
Okay. Yeah. Okay. Now I've noticed a couple of times while we've been talking that you've sort of looked round you into the room as if you're checking for something. Could I ask you what's happening at those times?
Well, I can hear them talking about me.
Right. Who is it you can hear?
My housemates.
Right. So that you recognise it as their voices?
Yeah, I can hear them all the time.
Right. How many voices can you hear, Andy?
3. There's 3 of them.
Okay. And do they sound real, like my voice sounds talking to you now?
Yeah, it's odd. It's like I can hear them when they're not here.
Right.
And
so what they're not when they're not in the house with you?
Yeah, it's like they're in the other room or something.
Okay. Okay. And can you hear what they're actually saying?
Yeah, they're talking about me.
Right. Okay.
They're always talking about me.
Okay.
They're always commenting on everything that I'm doing.
Right. Can you give me an example of what they would say?
Well, like if I'm packing my bag to go to uni or something, they'll comment on that, like he's left the house now. Or,
okay. Okay.
You know.
Anything else? Do they ever talk to each other, perhaps, about you?
Yeah, that's what they do. I mean, and now they know. They've sort of twigged that I know about them now,
right.
And they're saying like I'm making trouble.
Okay.
And that they're going to sort me out.
Okay. Okay. What about actually talking directly to you in the way that I'm talking to you now? Does that ever happen, Andy?
No.
Okay. So you've been hearing the voices of your housemates. Have there been any other changes? Have there been any changes perhaps to the way you're thinking? Sometimes people tell us that their thinking changes in some way. So, for example, they might feel that they're getting thoughts put into their head that aren't their own. Have you had any experiences like that?
Yeah. I do think things that aren't me. Like they're putting stuff in my brain. It's not me. I'm not thinking.
So different thoughts in your brain.
Yeah, that's like it's stupid stuff as well. It's like the other day I suddenly just started thinking about some woman in Coronation Street. I don't watch any of that crap.
Right. It's not your kind of thing normally. Right.
They're not my thoughts.
Right. Okay. And do you have any idea how that's happening, or who's responsible?
It's MI5. It's this chip they've put in my head.
Right. Okay.
And I can feel it all the time.
Okay. So you're getting thoughts put into your brain that aren't your own. What about a different sort of experience? What about the experience that somehow other people are able to know what you're thinking, even though you haven't actually told them?
No.
Nothing like that?
They're just putting stuff in my head.
Just putting stuff. And can I just check, Andy, as well, that you're not getting the experience when your thoughts just stop altogether, like you have no thoughts left?
No. If anything, there's too much in there. I wish I could unplug it.
Okay. Okay.
Just get this thing out of my head.
Right. And you mentioned this chip or this device in your brain. Do you want to tell me a bit more about that?
Well, it's a tracking device, so they know where I am at all times, and that I can feel it moving around, like rotating
so you
around.
can feel the physical sensation in your brain. Okay. Okay. That must be very difficult for you.
I don't know why they're doing this to me. I've done nothing wrong.
Okay. Can I just check, are there any problems, Andy, with the rest of your body? Any changes in sensation or any bits that feel different in any way?
No, I feel fine. I'm not ill or anything. I just want this thing out of my head.
Okay.
All right. You can now...
Yeah.
Yes.
Can I start?
Yes, you can now start.
Yeah. Dear examiner, I would like to present a mental status examination of my patient Sam, who is 21-year-old, and he came with some distressing episodes. So, in terms of appearance, he was well dressed as per weather. He was well groomed, and his facial expression was very anxious. He was cooperative and was not maintaining eye contact, but he was with depressed, showing stoop posture. In terms of the speech, he was having slow and monotonous speech. His mood was congruent with the effect which I observed. He was having auditory hallucination, which because he was listening some voice in his head. His thought form are linear, and he was having some delusion of reference. And he was not having any suicidal thought. In term of cognition, he was. We haven't asked about that. Insight, I think insight was uh, not intact, and maybe judgment is also impaired in him. And as a risk of suicide, as we didn't ask the question about the suicide, we can't say that. We were able to maintain the rapport with the patient, and history was reliable. But I would like to collect some collateral history from a highest family member.
All right. Thanks, doctor. So it was good. Few
Yeah.
things was missed after. So definitely in the
Yeah.
appearance, you can say all of this. So you can say that, well, as in terms of appearance and behavior, patient was dressed well dressed according to the weather, well groomed, and patient was sometimes not maintaining eye contact, was cooperative. He was not restless or fidgety. He was not sitting in a stood posture, but he was responding to some unseen stimuli. Very important. His speech was slow, monotonous at times, and some of the other times it was normal in tone, volume, and rate. Emotion, it was not assessed. So if something is not assessed, just say emotion was not assessed, but the affect that I have observed seems to be disturbed. Or you can also say that this kind of the affect seems to be a bit restricted. He's not showing all the emotions in here, right? So even if you say that affect
Yeah,
is
right.
restricted, that will be very good. So you can't comment on the
Yeah, that would better.
mood. Yeah, comment on the mood because it was not assessed or asked. So you will always say that the emotion, in terms of emotion, mood was not assessed, but the affect I have observed seems to be restricted. Perception, he had auditory hallucination as well as tactile hallucination. Auditory hallucination because he could hear his roommates talking about him, and also they definitely make sure to ask that can you hear the voices. So it was auditory hallucination, and also he thinks that there is a chip mi5 has inserted in his brain, and that's rotating in his
Yeah, I know.
inside. That's the tactile hallucination. Okay, there was no chip or anything.
Yeah,
That's a physical sensation of
yeah, got
something.
the point.
As part of thought form, it is linear. Thought content, patient had paranoid delusion, very important because he thinks MI5 is after him. Delusion of reference because the roommates and everyone is commenting on him. Okay, so those two
Yeah.
delusion was there. There is another delusion was there. What was that, guys?
Persecution.
No? Thought insertion, yes, it very good. Yes, because he said that there are too many thoughts, right? And there are some thoughts that's not mine. But they also,
Yeah, right.
if something negative is assessed in there, like it was assessed if the patient has any thought withdrawal or thought blocked, like when the doctor asks that, is there any time that there is no thought at all? That's what we call thought block. Okay, so there was no thought withdrawal or thought block. So those two was assessed. So if something is assessed and still it is negative, we need to mention that in this video. And insight, cognition, judgment was not assessed. As part of risk, patient has active hallucination and delusion, so he's definitely to be moderate to high risk. Rapport, the doctor was able to maintain a good rapport with the patient, and the history is not reliable. So the most likely in here, the doctor will need to take collateral history from the friends or roommates. Okay, so in here we will not say we are going to take collateral. The doctor will need to take collateral history. Sounds right?
Okay, it sounds right. Yeah.
Yeah.
Thank you, sir, for giving me
Thank
a
you.
chance.
No worries, Dr. Aptav. Keep it up. Thank you.
Thank you.
All right, guys. So I hope you are enjoying our sessions. I hope these are making sense to you. Most of you are still like just started doing these role plays. And if you just started and you're doing like this, I'm really happy because many of you really did well tonight. I know few of you are from our last batch, so that's okay, but still you're doing really good. So I'm really happy that you're doing practice, and it's showing when you're doing the role play. Okay, so pretty good. Now, if you guys have any questions about the course, feel free to ask me. You can ask any questions directly. But for enrollment of the course, so if any of you wants to know more about the course, then you need to just go into our website. So I'm going to show you where to search for it. So if you write firstaidamc.com.au, so just write firstaidamc.com.au, our website will come up. And then if you go to the 5 months extensive clinical course, that's where you will get all the information. And this is where you can register for the course. So if you click on register now, then it will take you to the necessary steps one by one. Okay. So the course has everything all together. The course is not subdivided into multiple divisions. We don't do that. We make sure once our students enroll into the course, they get each and everything inside the course so that they don't need to feel like go everywhere to find out the things that they need to learn for the exam. Once you get into the course, everything is there. There is nothing you need to do except just make sure to read our notes, make sure to practice what we are discussing in the course, and you should be well enough to pass the exam. Okay, so prompt type is it? Prompt type will be like 3 minutes for MSc after video. Prompt time, so usually it is 4 minutes watching the video and 4 minutes for giving the MSc finding to the examiner. Yes, you can pay fees in installments. So there are 2 installments that we offer. Diazepam overdose, yes, that patient is high risk because he's already having suicidal thought. No, you will not be penalized if you finish before the 3 minutes. It's fine. As long as you cover everything. There is no change of edition in AMC clinical handbook. It's all the same. It's been always the same. So years and years, it's the same handbook people are reading, but it is still the same because those cases do not change. Sometimes a little bit of management changes, which we discuss in the class, but the handbook that we will give you in the course, that will be more than enough. Can we ask 2 questions to the patient at a time? How do you like it? We can, but it cannot look a bit odd. Like ideally, we say that, do you have any chest pain or shortness of breath? Do you have fever or cough? Do you have muscle aches and pains or joint pains? So sometimes we do that, but there is always a chance that patient can say one information and then they can forget the other one. So the important ones, like if this is a case of CVS, a cardiovascular, then better not to ask 2 questions of important symptom. Like if you ask chest pain, shortness of breath, and it's a cardiac history, it's better to make sure that that patient doesn't have chest pain or shortness of breath. So ask it one by one. But let's say chest pain case, reflux is not your first diagnosis. So you can always ask that, do you get burping, belching, or heartburn? So we can ask like that. Okay, so it depends. Schizophreniform illness is based on duration. If we want to diagnose a patient as schizophreniform, the duration of symptoms should be more than 1 month and less than 6 months. When the symptom duration is more than 6 months, it becomes schizophrenia. And if it is less than 1 month, we call it brief psychoactive disorder. So that's why in diagnosis cases, always ask the duration of symptom. Very important. Yes, there will be more. There is 4 psychiatric class. So there will be more because this is just one part of psychiatry. So for course student, there will be more topics. Yes, definitely. All right. So please go through the details if you want to know about the course. So we have full theory, like how we are doing as a cluster wise. Your next class, if you are in the first aid AMC clinical group, you will know our next class is going to be on 13th of January. So that's just in 2 days time, right? So on Tuesday, you will get a random role play session with one of our mentor. So that's not me who is going to be in that class. So you also get to learn about our other mentors. So those random role play sessions, we just give you any questions and we ask you to do role play. So in those random role play class, our ex-students also join. And our ex-students also do role play with our mentors. So initially, you will get to learn from our ex-students how they're doing the role play. That will also give you some idea. And our mentors will also discuss the case, give some feedback. And I always encourage even the new beginners, just come and do the case. Whatever you feel about the case, try to do it, and you will gain more and more confidence as you go. But those classes are nightmare initially for beginners. So please don't get overwhelmed because you don't know anything about the cases. So if we give a random case to you, it's normal that you will feel very, very like very surprised and very up. I don't know what to say. Like you will not want to do role play. So, but I want you guys to come out and do role play with us, even if you're not sure. Okay. So same time, Sarah. So all our classes are 8:30 p.m. Sydney time. And yes, so thanks Nasser to share the Facebook group. So this is our Facebook group. Even if you search First Aid AMC Clinical, it should come up on the Facebook. There is no discount for old student pronouncer unless you are like the students who just finish the last batch. And if you finish the last batch, you really don't need to join the new course. The last batch was enough for you. Yes, that's right. Yes, it. So you also get, like Nasser, you also get the last 1 year. So last batch, whatever we discussed, you will also get the full recordings of the last batch as well. So if any of you don't have enough time, like you got your exam in March, April, May, then those previous batch recorded sessions will be really important for you to go through. So we covered theory. We also do the recent cases role play, which is that random role play sessions. There are 5 years recent question discussion in the course. So there is a lot of role plays that we have done. All those things are available to your student portal. And the recent new cases we discussed in the class as a live session, like how we are doing now. Okay, so go through this. If you have any questions, feel free to ask me. But we can assure you that if the course is all that anyone will need to pass the exam. Um, the role play that we are going to have next class, no, it's not on psychiatry. It will be with anything. No, Shah, there is no preferable day or month to book the exam. The exam is always hard. So any month you are going for the exam, it is hard. It's going to be the same more or less when you book it. So book it when you feel you are confident enough. No, Yazid, those random role play classes, we will not give you the case. Like we will not do that. In our other role play classes, like the theory role play session that you will have with me, you will know the cases, like how you had a bit of an idea today, like what is gonna be. But random role play is kept in that way so that you get the test of exam, because in exam you don't know what's coming in your exam. So we in the course in 5 months we want to make sure you can do role play, you can do a case not by not knowing what it is. Eventually after a couple of months when we discuss more theory, you get more ideas, those random role play classes will become easier because you will have that technique or approach in your mind how to do that. But initially it is difficult, we do understand that, but again we have to make sure you are prepared for this exam like as early as possible, and we want to make sure you get the test of exam. The current course is aiming for, so our course will finish in end of May, so you should be aiming for appearing the end of this year. So aim for October, November, or even if you're good, then I would say anything from August to November will be your exam. So you should prepare for that. Okay, all good, guys. Thanks for active participation. The next class will be on 13th. So join at the same time, is the same Zoom ID and password. And after that class, we will start the cardiology. So you will get to know a little bit about medicine as part of this free session as well. Okay. Thank you all. Have a good night. Take care.